Okay, this is a cardio question. 22-year-old man is unresponsive in the dorm room, pronounced dead at the scene. He has no history of smoking, alcohol, or drug abuse, and he's got his mom had a heart transplant at 42, and he's got a mutation in the TTN gene. So they could have said that he uses cocaine and alcohol as well for this type of question, but TTN is enough to answer it. So the correct answer is ventricular dilation with myocyte degeneration. So this is dilated cardiomyopathy because of the TTN gene. So this is the most common types of cardiomyopathy. Alcohol, cocaine, and doxorubicin can cause this. Coxsackie and Chagas virus can also cause this. It's associated with hemochromatosis, sarcoidosis, thyrotoxicosis, and wet beriberi. Basically, anything that damages the heart can cause that dilation. You treat it with sodium. We'll talk about that in a second. But stress cardiomyopathy, also called Takotsubo cardiomyopathy, broken heart syndrome, when a big sympathetic stressing event happens, this can cause dilated cardiomyopathy as well. So this is a sudden cardiac death, and so it suggests dilated cardiomyopathy, the TTN gene coding for the titin, which is a sarcomere, and it's a genetic autosomal dominant with incomplete penetrance. So it's, you'd see the balloon heart, myocyte degeneration, and fibrosis. So less muscle, more dilation. DCM, dilated cardiomyopathy, leads to systolics. You hear S3 sound, increasing the risk for ventricular arrhythmias and just sudden death. Absence of hypertrophy is a big clue as well. So the other ones, fibrofatty replacement of the right ventricle. That would be if you had desmosomal proteins, not the titin ones, mutated. Myocyte hypertrophy and myofibril disarray. That would be your hypertrophic cardiomyopathy, and that's the young athlete sudden death caused by mutations in the sarcomere proteins in the beta myosin heavy chain and the myosin protein binding C. So that would be asymmetrical septal hypertrophy. And so you'd see one side's way bigger, and it wouldn't be dilated. It'd be just one side is hypertrophic, but it wouldn't be dilated on both. So then we have the endomyocardial fibrosis. That'd be restrictive cardiomyopathy due to left lower endocarditis. This is commonly associated with, so restrictive cardiomyopathy is commonly associated with amyloidosis, hemochromatosis, and sarcoidosis. And restrictive cardiomyopathy can also cause interstitial fibrosis and atrophy. And so that wouldn't dilate, it would just be atrophic. So DCM, dilated cardiomyopathy, is a big and a weak heart. It's super dilated and fibrosed. The TTN titin mutation causes this, and it causes sudden death. And you can differentiate this from hypertrophic cardiomyopathy because they have the thick walls and myofibril disarray. So talking about how we treat this, sodium restrictant. So I said you treat it with sodium, but you treat it by reducing the sodium because that has less fluid be retained and decreases the preload, and that lowers the strain on the heart because right now the heart is really damaged and strained. So you got to reduce that preload. ACE inhibitors can also decrease the afterload because it dilates the arteries and makes it easier to pump, so just like reduces the work, and reduce aldosterone levels as well, which prevents fluid overload and just is good for survival rates. Beta blockers reduce the heart rate, so there's less oxygen demand. You can also use, like with valsartan and some other things. This is really important for step one, but sacubitril can lead to vasodilation. So basically the precursors of the natriuretic peptides, if you inhibit those, then this can be used for treatment of dilated cardiomyopathy because you'll vasodilate and cause the sodium excretion, which then reduces the blood pressure, which then makes it easier for the heart and prevents its failure. So then diuretics, of course, to reduce the blood volume, and spironolactone as well to block aldosterone, which reduces fluid retention. The basic idea is just like kind of less strain on the heart transplant, and a defibrillator. So basically hemochromatosis, sarcoidosis, thyrotoxicosis, and wet berry cause this, and also titin is incomplete penetrance with autosomal dominant inheritance. And yeah, that's pretty much all we need to know for this type of question. So hopefully this was helpful. If it was, like and subscribe, and we'll keep making content.